Hi, I'm Dr. David Reiss. Welcome, and I will just give people a moment or two to file into wherever they are, and we will get started. I'm not going to give a countdown, but I will wait about a minute or so and then get started with the presentation. Welcome to everybody. I'm Dr. David Reiss. I'm a psychiatrist. Welcome to this presentation. I have some of my basic demographics up there, but just to give you a brief overview, it says I've been in practice 30 years. Oh, been a little bit more than that, but thank you, Scylla. But I'm a psychiatrist working out of San Diego remotely since the pandemic. I was on both coasts prior to that. Just briefly, my sports medicine background goes back to Northwestern and med school. I won't tell you how far back, but it goes far back. I've been involved with CLF for about 15 years. Part of my work with concussions and concussion-related mental health issues is through the California Workers' Comp system, which I've been involved with for 30 years. And just very briefly, the laws have changed, but it used to be that any athlete who claims an injury occurred in California, regardless of what team he was playing for, whether it was a California team or not, could file a claim under California Workers' Comp. So I've evaluated any number of athletes with basically stress or mental health claims secondary to sports injuries. But I've also been involved with athletes in various other venues, and currently I'm the staff psychiatrist for AEW Wrestling, working with their roster actively, not only concussion issues, several mental health issues. But I'll leave that. I have no financial relationships to disclose or anything like that. Just to remind everyone that this presentation is eligible for free AMA credit, an hour credit. You can get a participation certificate, and the information on obtaining that will be in the chat and will be sent afterward in an email. Part of what I'm going to be talking about, well, a lot of what I'm going to be talking about is the complexity of these issues. When we're dealing with neurological problems, and I am not a neurologist, I will not be going into specific neurological issues, combined with psychological, psychiatric issues, it becomes very complex. And I think we'll notice it even in the presentation that I've tried to outline what I'm going to talk about, but even then I'll be going back and forth because one issue leads to another issue, leads back to the first issue. We're dealing with a very complex situation. So just to start out with some definitions, concussion, it's basically trauma to the brain. And this is a little bit of history. When I first started in my training, a concussion was defined as loss of consciousness. Someone could have a major hit to the head. If they didn't lose consciousness, it wasn't clinically considered a concussion. Obviously, we know a lot more about that now, and anything that makes the brain jiggle and bolt and jump and jolt within the skull basically causes a concussion. We've come a long way from them, still a lot we don't know. Post-concussive syndrome is defined as symptoms related to a concussion lasting more than 1 or 2 months. Again, I'll leave the details to that to neurologists. And CTE, we're talking about the degenerative disease that can arise, doesn't always arise, but can arise from concussions that we still cannot clearly diagnose in a living person. We can certainly suspect it, provide some treatment and intervention, but the actual diagnosis requires studying the brain. Again, I'm going to defer that to neurologists to talk about in detail. moving more into my area, uh, what I'm going to talk about is the interaction of concussions, concussive injuries, and mental health issues, which are by definition extremely complex and interrelated and not at all linear. But just to define some general terms, one term that I'll be referring to multiple times is PTSD. A little history on that also, just briefly, when I back in the early years of my practice, not only training, we did not use the clinical term of PTSD unless someone was directly exposed to a life-threatening event or witnessed a life-threatening event. That made some sense at the time because we were dealing mostly with military-related PTSD. We now have a much better understanding, although far from a complete understanding. And really, PTSD is any event, and it doesn't matter how objectively stressful or traumatic it is or what someone else thinks about it, any event that puts a person into a fight or flight state, basically sense of danger, the autonomic nervous system, the mind, the brain, cognition go into a fight or flight mode. If it's brief and it resolves, often it's just you experience it, goes away, that's it. But if it's severe or if it's repetitive, even if it's not severe, you can have PTSD that becomes chronic, that can fluctuate and impact not only just the sense of fear and the typical things we think about in terms of fight or flight, but all emotional reactions, anxiety, depression, and even cognitive functioning. I talk a lot about the perception of time. People who are exposed to trauma will say, well, time stood still. Well, if someone has a chronic PTSD, they're always functioning at that level in terms of perceiving time. And it's as if time is a bubble where more and more things are thrown into it, but you lose the linearity of it. So PTSD is extremely complex. And when we're talking about both the neurological and psychological aspects, which we'll get into, it very much complicates a lot of post-concussive type issues. Attention deficit or disorder, ADD, that was the diagnosis that was basically reserved for kids and teenagers. We now use it for adults also. In this venue, I'm not going to be picky about a specific diagnostic criteria, which may require problems earlier in life. I'm going to say if someone has problems focusing, concentrating, paying attention, hyperactivity, practically we're dealing with ADD or ADHD. And some of the treatments are the same. Surely what we're seeing is the same. And whether it was present in childhood or adolescence or not becomes somewhat irrelevant. On the other hand, especially when you're dealing with a population of athletes, there tend to be more people with PTSD within that population. Some of it is because people with, not PTSD, with ADHD, people with ADHD will tend to enjoy physical activities more. They may do better in that, so it's more rewarding. But we do see a higher percentage of people who have a history of that, which makes it even more complicated. Somewhat similarly, and I've listed this separately as opposed to other things that I've grouped together, is obsessive compulsive disorder. And here I'm not just talking about formal OCD, which we believe to be basically neurologically caused, and that may be innate to somebody's neurology. It can be acquired through injury, but we also have obsessionality as a psychological defense mechanism, as a reaction. And particularly when you're dealing with whether it be athletes, first responders, law enforcement, doctors, lawyers, people who are dealing with these types of issues, this type of intensity, it helps to be a bit obsessive. So especially when you're dealing with a population of athletes who are functioning at a high level, whether it be college, professional, there is a preponderance of people who have obsessive tendencies. It may not be full-blown OCD, but it's something that's often there beforehand. that then may be neurologically or psychologically exacerbated by the effects of concussion. And we'll get into that in more detail. And finally, and I've grouped it all together, but we'll talk more specifically about the general emotional effects that people have to these types of injuries in terms of anxiety, depression, at times mania, which again may be a pre-existing bipolar disorder or maybe a neurologically triggered bipolar looking disorder, paranoia, problems with impulse control, problems relating to people. I'm going to talk a little bit more detail about each of these areas, but they all interact. So please bear in mind that I'm going to be going back and forth between these areas, since area A affects area B, which affects area C, which then affects area A, et cetera, et cetera. We'll get into that in detail. Just to talk about some of the different aspects of functioning, particularly in the mental health area, that can be impacted by concussions. Obviously, you can have the neurological effect due to changes in the brain that affects mood, that affects thinking, that affects impulsivity. And I'm not going to go into the neurological details, but we have very neurologically based psychiatric and psychological effects of these types of injuries. But then you also have the psychologically based effects, and of course, those two reverberate with each other. And what I've put up here is just the awareness of a change or a loss. You know, someone who is aware that they have been affected, that they're not functioning the way they used to, is going to have a different emotional reaction than someone who's oblivious to it or is unable to appreciate it. So we have to take into account not only the physiological and neurological changes, but what are the emotional effects of being aware or unaware of those changes? And on both sides, does the awareness of the changes impact how someone sees themselves and others? And we'll get into more detail with that. Or if someone is unaware, are other people seeing things that are going to affect how they react to someone, and the person's going to be at a loss to understand that? All leading to a lot of complexity and multiple different emotional responses. All of that is superimposed on each of our personal neurochemistry. You know, in plain language, we're not all wired the same way. We don't all have the same biochemistry, and whether we're talking about physiological, neurological changes or psychological changes, we're all different. These days, we talk a lot about dopamine and we talk about other neurotransmitters, and all of that definitely has a reality and it's helped us to understand and to be able to provide some interventions. But they're all approximations for a system that's so complex that we're barely scratching the surface. You know, like I sort of referred to a few minutes ago, looking back to my training, we can see that a lot of what we believed then was really not even true, let alone incomplete. And I expect 10, 20 years from now, we'll be looking back to this presentation and looking at it with the same shake of the head that I'm looking back to 30 years ago. Then in terms of other impacts on mood, emotions, and how emotions then affect cognition, which is already affected on a biological level, I've just put a couple of areas here, and we can see that these are all interrelated. Obviously, disruption of work. If someone isn't able to be productive, if they're not able to support their family, if they're not able to function with coworkers, how does this impact their emotional state, whether it be anxiety, depression, sense of self? How does this affect their relationship? If you're not able to communicate, if you're absent at times in terms of just being present in the moment, if you're more impulsive, if you're more irritable, or on the other hand, the other side can be too. Sometimes people become more dull, unreactive. That can also impact relationships. And we're talking about relationships, whether it be in the workplace, whether it be in personal relationships, significant other, children, parent, family, etc. Obviously, the ability to participate in physical activities, both on a physical basis, on a neurological basis, but on a motivation basis. and then the ability to get enjoyment and relaxation from those activities. And you may say, well, enjoyment and relaxation doesn't really relate to work, but in a way, even that is interacting, because if you can't at work be able to take some space to relax, if you are always uptight about your work, the inability to relax, the inability to enjoy, let's say, a coworker joking in a normal way, can have an impact on the quality of work, can have an impact on how you perceive yourself. And that all goes to the next area that I have down there, is the sense of identity. Who am I? What do I do? How do I function? Now, some people have very solid sense of identity. Some people's identity are a little more squishy, and it doesn't take much to have them question who they are or feel uncomfortable or feel that they don't fit. Obviously, that relates a lot to self-esteem. How do I see myself? How do I view myself? How do I think others see me? And the sense of pride. And this cuts both ways. Clearly, people who have a tendency towards having low self-esteem or being self-deprecating, if they feel they're not functioning at 100%, if they feel they're impaired, that's going to increase their sense of low self-esteem, and that's going to lead into anxiety and depression. But sometimes overlooked is the other side, which isn't all that unusual, particularly when you're dealing with, again, it doesn't matter whether it's athletes or other professionals who are functioning at a high level, people who tend to be a bit more bombastic or even a bit grandiose. If they lose that ability, if they lose the ability to be grandiose, if they lose the stage, if they lose the the support from others, if they lose hearing back how wonderful they are, that can affect pride, self-esteem, sense of identity, all of which can interact and cause anxiety, depression, etc. And this is all superimposed on what each of us have a innate temperament. And when we're talking about innate temperament, we're talking about, you can see in an infant that they may have a tendency to be reactive or not particularly reactive, be happy, to be more serious. So all of this is superimposed on, was the person to begin with a serious, intense, sort of self-critical person, just sort of average, or sort of happy-go-lucky, or tending to use a lot of denial and be overly optimistic. All of these things, as you can imagine, have a very complex interplay, which we have to take into account diagnostically and in developing an appropriate understanding of the person's problems and how do we intervene to try to help. And then the other issues, so taking a little bit deeper dive, I have written down personality dynamics, past history, and trauma. Obviously, if someone has a history of PTSD, or even if they have a history of having been traumatized that did not lead to a formal PTSD, having a traumatic event or a traumatic loss, which includes just the loss of cognition or loss of job, is going to interact with their past and who they are and what they've experienced. And it may awaken conflicts that previously seemed to be resolved or at least quiescent. We have to be very aware of that. And I'm going to talk in more detail about it as we go, but substance abuse, any substance that impacts mood, impacts cognition, impacts your state of mind, may have good or bad effects on people who are dealing with these types of issues. Clearly, the most common thing we see is alcohol. I should say the most common dangerous thing we see, because that makes everything worse. Alcohol is a chemical depressant. It interferes with cognition. It interferes with judgment, but it's very easy to turn to. It's legal, it's available, and we often see that as a factor causing more complexity to treatment, more complexity to even understanding what's going on. Obviously, other illicit drugs do other things. I won't go into all of them or details. But even the effect of prescribed medications, whether they're taken as prescribed or whether sometimes they're taken not quite as prescribed, which can go in both directions, overusing abusively, or using intermittently, not really following instructions, can cause problems. The one area that I'm seeing a ton of issues right now, it's not quite as dangerous as alcohol, but it creates, in a sense, more confusion, is marijuana and weed. Obviously, it's legal in a lot of places. And there's some aspect, there's some chemicals within marijuana that may actually be decent treatment for some aspect of what we're seeing. But on the other hand, there are other chemicals and there are other effects of marijuana which make things worse. The most obvious being memory. And that's something I'm dealing with almost all the time. I'd say like 80% of the time in athletes that I deal with, whether they're actively athletes or actively completing or retired, is they'll be using weed to one extent or another. And when you're evaluating memory, unless you're doing really in-depth neuropsych testing, what is the weed they used last night? What is the gummy and what is the concussion? Very hard to differentiate it all. It makes things much more confusing. And then obviously normal life stresses. We all have various stresses. I just have some of them on the little chart there. But when you're dealing with a post-concussive condition, when you're dealing with anxiety, depression, cognitive impairment, how we react to everyday stresses is going to be different. Whether we can resolve them, whether we can cope with them, whether we're going to panic over them, or whether we're going to go the other way and ignore them, and how that is going to impact our relationships, our sense of self. Those are other issues, and they're not static issues. Obviously, they're going to change hour by hour, day by day, month by month. And when you're treating someone these issues, you have to be aware of that, not a static situation biologically, neurologically, psychologically, or psychosocially. Which goes to, in evaluating someone, what do I evaluate when I'm looking at someone who's coming with mental health issues and a history of concussions? And I'm going to go to sort of the last thing that's on the chart there first, which is the nature of the injury. It makes a difference whether the concussion symptoms are due to a specific injury, a number of specific injuries, or maybe cumulative injuries that the person didn't even take seriously while they were occurring. That's going to set up a different way of coping, a different way of understanding, and a different emotional response. Connected to that is the level of trauma involved in the injury. Was this a very traumatic injury? Was this something that the person didn't really think twice about? Or, as is common with athletes, well, I can remember 3 or 4 or 5 or 6 times I really got dinged, but most of the times I didn't even know it was happening. All of that can impact how someone sees themselves, how they react emotionally, and whether or not it's triggering post-traumatic symptoms, and not necessarily a fully diagnosable PTSD, but post-traumatic symptomatology. Related to that is, and this is common sense, often if someone has a head injury, it's not the only part of the body that's affected. So what other injuries are present? What other impairment is present? What has the person experienced in terms of loss of ability, loss of self-esteem due to other physical injuries that are occurring? And, one of the things we're almost always dealing with, particularly in this population, is chronic pain. I typically will ask the athletes I work with, when was the last time you woke up and you weren't in pain? And I don't mean acute pain like you just got injured, but you woke up and you weren't in pain. The typical, almost universal response was somewhere midway through high school. And that may be someone I'm talking to who's in their 60s. Last day they were pain-free may have been in elementary school. How is that interacting with how they're going through the day, what their mood is like, what their level of irritability is like, etc. So it's very important to get a full medical history when I'm evaluating someone. Not that I'm doing the evaluation of the medical issues, but I need to know about them. Does the person have a seizure disorder, pre-existing or from the head injury? Are they on medication for that? And what other body systems are having problems, whether related to injury or whether related to totally separate medical conditions. Obviously, over the last several years, COVID has been a big issue. I've had any number of people who we haven't been able to clearly sort out what cognitive changes were due to concussions, what was due to COVID, what's due to long COVID. And although COVID's the most obvious, many other medical conditions can cause similar type problems that you have to take into account. Clearly, you have to evaluate the person's psychiatric history. Did they have a history of anxiety, depression, OCD, ADHD? That the best we know pre-existed the head injury, the concussive injury. Has that made something that was already a problem worse? Particularly with issues that affect cognition, which include ADHD, ADD, and PTSD, but as well as anxiety and depression, because the typical, what we call neurovegetative symptoms, anxiety or depression, are disruptions of sleep, disruptions of concentration, disruptions of memory, all of which are also symptoms of post-concussive problems. So where do we draw the line between these? It's almost impossible to. Very detailed neuropsych testing can give us a hint. But again, what is causing what changes over time and may or may not have been a problem beforehand has to be taken into account on an ongoing basis. And then obviously, which I've already sort of touched on, is the person, just their personal history, their psychosocial history. What was their youth like? What were their childhood relationships like? Were they traumatized? Or on the other hand, were they sort of big man on campus, big woman on campus, and now has lost that ability to have that leadership role? So you're not just looking at what has this injury done, but who is the person who has had this injury? You know, and that goes back, it's been attributed to many people going back to, I think, Socrates, that good medicine is not treating disease, it's treating the person who has the disease. If you don't know who the person is, was, could be, hope to be, it's hard to really put in perspective what they're experiencing now emotionally. Going along with that, you know, some of the more specific issues we have is what are the person's personal life circumstances, both in the past, but also currently? Do they have a good support system? Is it someone who, if they feel they're maybe not holding up their end in some ways, and reach out for help, have people willing to help, have people who are understanding? On the other extreme, are they people who are in a toxic environment where the people who are important to them may not accept what they're going through, may not acknowledge it, may blame them? All of that has to be taken into account because, again, all of that affects mood, anxiety, level of depression, level of despair. And that includes what was the person's hopes and plans and aspirations, and have those been affected by what happened to them neurologically, physically, and emotionally? You know, often I'll see people who plan that, well, after my athletic career, I was going to do this or that, but now I can't. Well, what does that mean? What does that mean in terms of supporting their family practically, supporting themselves, self-esteem? It can lead to fear. It can lead to despair. It can lead to despair that becomes dangerous if someone really feels that all their hopes are gone and they have nowhere to turn, as well as just exacerbating the post-traumatic symptoms and whether it be formal PTSD or more subtle PTSD. But it's important to, just as I said, to know the person, to know not only the person as they were and as they are, but who they hope to be. If you're not taking that into account, you're missing a big part of what may be driving anxiety and depression and fear. It may not be just what I'm experiencing today, but what I fear I'm going to experience tomorrow and next week and next year and 5 years from now. All of this is superimposed on what I'll just generally call personality dynamics. So basically, who the person was, basic traits. Is it someone who tends to deal with things in an intense way or an obsessional way, as I've mentioned? Is this someone who's more happy-go-lucky? And what motivation do they have to work on issues? Are they people who rely on denial? Are they people who really take a deep dive into everything and catastrophize and will overly worry about things? Uh, and going along with this, it's somewhat different, but it's related. Is what was the person's level of social skill to begin with? If you have someone who had good social skills and then they have slight impairment, they can more easily find ways to compensate. But if you find people who are either very narrow or had specific problems or difficulties or just somewhat awkward relating, that can be very much exacerbated by, again, both the physiological, neurological, and psychological aspects of the effects of concussion and head injury. Related to that in terms of social skills is dependence and independence. And this can be particularly problematic in the population of athletes where dependence and independence is often a conflict because on one hand, high-level athletes need to be very independent, but on the other hand, you always have someone to answer to, whether it be a coach, whether it be a team owner, whether it be a fan. But even on a more interpersonal level, often people at home aren't the same as they are on the field. Is this someone who is able to adapt and try to improve their independence despite having perhaps less ability than they had before? Or are they someone who's going to fall into being more dependent or overly dependent, sort of give up on themselves? And is that something that needs to be addressed therapeutically? So all of these are confounding issues that need to be evaluated, need to be taken into account, and need to be addressed. Those particular issues aren't going to respond very well to medication by and large, but are very important to understand in therapy in terms of a person's relationship and their level of dependence and independence with friends, with family, with colleagues, with bosses, with supervisors, if they're working with coaches, et cetera, if they're still performing. These are issues that may fall under the radar, and unless you ask, you don't know about it. And it's very easy to assume that because someone has a larger than life persona publicly, that that's who they are privately. Not necessarily the case. I can't tell you how many times I've been in sessions with people, and this isn't all sports for the most part, where the person will say, I have a great problem with confrontation. I have a great problem with being assertive. I really don't know how to speak up for myself. And the first response is, did you see yourself on TV last week? But that's a different venue. It's a different aspect of the personality. And that aspect may not be present, but you may have the opposite in a person's personal life. And that's one thing that I see therapists often missing is that someone whose public persona may appear one way, privately may be very different. And if you don't really address that, again, in terms of family, in terms of personal relationship, in terms of identity, in terms of sexuality, in terms of sexual identity, you may miss some important aspects of what is causing anxiety, depression, fear, post-traumatic reactions, and that can get in the way of providing the best comprehensive treatment we're able to provide. Just in terms of modes of intervention, and there are a lot of pictures up here, but basically what I'm saying here is that counseling, I'm old school, counseling is indispensable. Even if someone has no real insight to look into issues, just to have someone to talk to, just have, whether it be a counselor, whether it be peers, someone who you can present what you're experiencing, what I have on bottom there, whether it be grief, whether it be suspiciousness, whether it be boredom, and to be able to talk about it, to be able to exchange ideas on how to cope, different coping mechanisms. with the understanding that what works for one person may not work for another. But I think that counseling, whether it be formal therapy or informal therapy or peer counseling, is indispensable in working with these issues. Even in people who unfortunately become significantly cognitively impaired, it's still important to be able to make contact with them, and it's still important to respect their humanity. And that can get lost at times. And when it gets lost, it tends to sometimes under the surface just create more despair that you may not even see in terms of classical symptoms, but is going to be making everything worse. Before getting into different types of therapy, the other thing that sometimes isn't given enough attention is quality of therapists. And I'm not talking about only just the clinical knowledge, which obviously is important, but other issues, just the demographics and personal experiences. Some people feel more comfortable talking to people who share their demographics, be it sexually, racially, background, who share their experiences. Dealing with athletes, now, like I personally have never done anything sports-wise beyond schoolyard. Like I said, I played basketball for 60 years and I probably scored 30 points. But on the other hand, I've been around sports. I know how the systems work. I know how teams work. I'll often see people say they went to a therapist who was very good, but I had to explain everything I've experienced. It takes time and it often creates a distance. But you want a therapist who can make a connection and who just has an interpersonal style that works. Some therapists are more talkative, some peer therapists are more quiet, some therapists give homework, some therapists don't. You have to have a style that connects. Now, you always need appropriate boundaries. That's not saying that anything goes, and I won't get into the details of that, but there need to be appropriate therapeutic boundaries. You are a therapist, you're not a personal friend, but there can be different styles. In terms of dealing with these issues, I feel some of the most important abilities for a therapist to have, and I don't care whether you're talking about someone who's actually doing psychotherapy or counseling, or just a psychiatrist who's just prescribing medication. If you can't connect with the person, if you can't be adaptable, if you can't think outside the box, because there's so much we don't know about these issues, there's so much we have to try to piece together about the complexity. By and large, I know if someone's come to me, it's because the standard treatments haven't worked. People who basically their GP can give them treatment and that works aren't going to get to the shrink. They're not going to get to us. So almost all the people we're seeing at this level of clinical intervention are already sort of outside of that middle of the random spectrum range where the standard things are going to work. So you need a therapist, you need a doctor who's going to be adaptable, going to think outside of the box, and also know their limitations. That sometimes it helps to have an auxiliary therapist involved, whether it be to deal with psychosocial issues, whether it be to deal with sexual issues, whether relationship issues. Sometimes you need relationship counseling or couples counseling. My view is that it generally doesn't work to have the same therapist do individual and couples work or family work, because then where the boundaries are in terms of confidentiality get very cloudy. But also just for other areas. And I'm very open with the athletes that I talk to that, not everybody is going to want to really share certain things with a, white-haired 60-year-old geezer from New York. And sometimes you need to bring someone else in and work collaboratively. Make sure you work collaboratively and make sure there's good interaction. Not only in the sphere of mental health, but interaction with the treating neurologist, with the treating orthopod often, with the treating general practitioner. And believe me, these days that is not easy. At times insurance makes it almost impossible. I won't go into the details on that. I could go on for 3 hours about that. But if you don't have good integration of care, you don't have good care. So it's difficult, it's problematic. we can't always reach the point we want to reach, but we have to at least try to get. Modalities of treatment. And this is more talking about psychotherapy than medication, which I'll get to next. And I've just sort of put it into 4 general categories. There are a lot of subcategories into each of these. Psychodynamic, what I'm referring to is understanding the person's past experience, understanding how they work as a person psychologically, basically based on not only who they are, but what their past experiences are. Now, that doesn't mean that everybody needs to go back and rework all their traumas from the past or even recall all their traumas from the past. But we have to have an understanding of how that may impact what's going on presently and whether the person is able to use that understanding to improve their current situation. What I always tell people is, yes, I want to get a good history. I want to work on issues from the past, but only to the extent that it helps you in the present and the future. You know, the goal of doing psychodynamic therapy or explorative therapy, whatever you want to call it, isn't to write a book of, I'm really screwed up. This is how I got this screwed up, but I'm still just as screwed up. Yes, you can do therapy for years and understand it, not get any better. What you want to do is to be able to use that to improve your present and your future. If it's not being used in the service of the present and the future, it's not really particularly relevant. Now, often that knowledge is relevant, but understanding or reworking every past trauma or every past event sometimes just opens Pandora's box and makes things worse. But you do want to, for people who are able to go back and work with those issues, understand when those issues are there. Another type of therapy is just supportive therapy, where you're not really going into looking into deeper issues or deeper emotional conflict. It's just, what can I do to help you cope with what's going on now? That's pretty straightforward. But the thing you have to watch out for there is not creating too much dependency. You know, you want to encourage people to solve problems on their own to the best of their ability, to know when they need to ask for help or when they should ask for help, but not to feel totally helpless or totally dependent, where they may feel more comfortable being dependent, but it's really not good for them or their family, or it may actually create more depression and more sense of hopelessness, more or less a loss of self-esteem. These days, the big thing is CBT, cognitive behavioral therapy, which basically in a nutshell just means looking at what you're feeling and thinking and looking at how it affects your behavior and then seeing where the behavior really may not be adaptive and more based on what you're feeling than what the reality is. Really pretty simple and to that extent. And any good therapy, be it psychoanalysis or being a supportive therapy, includes cognitive behavioral work. For some people, that may mean doing actual exercises, paperwork, homework, journaling. Whatever works, works. But not everything works for everybody, and it needs to be individualized. The other thing, and this is a big issue with insurances these days and the system in general, is because the cognitive behavioral interventions are easy to study. Do this, and we'll see if that happens. You can do very nice studies on it that are a lot cleaner than psychodynamic or supportive work. So we have a lot of data. So what a lot of mental health has come to these days is everything should be treated with CBT. As I say, it's a very useful intervention. It should be part of every intervention, but the silly metaphor I like to use is if someone comes up to you and says, well, you know, I really want to make a really good stew. You say, well, you know, every good stew that I've eaten has had tomatoes and onions in it. Let's forget about the rest. Here's a tomato, here's an onion, go enjoy yourself. That's what I see happening with cognitive behavioral work at times. Is it useful? Yes. Is it important and basically always should be there? Yes. But is it enough of itself? Rarely. I won't go on in detail on that, but I think that's a big problem these days, particularly when you're dealing with the medical system and what we're supposed to be doing according to preset algorithms, which is statistically based. And I've never treated a statistic. I treat people. And though what statistically works for the average person, well, when you have an average person, please introduce him or her to me. I don't think I've met them yet. So we really have to look at these issues in a more comprehensive way. And that includes what I have on the bottom. Not everybody functions on this basis, but what I call existential issues. What is the person's sense of their meaning in life? What is their meaning to the important people in life? What is their meaning in terms of their legacy? What is their meaning in terms of what they hope their future to convey? These are important issues to talk about with anyone who suffered any kind of injury, particularly if it's a physical injury that causes permanent impairment, and even more so if it's cognitive injury that's creating a difficulty in functioning. What are the existential issues of who am I as a person? And being able to respect whether the person, some people just don't go there, some people bring very specific faith or religious beliefs in that are very helpful to them. You want to respect that. But if they don't have that, you want to find out what will work to help them deal with the question of meaning and what the meaning of their life is going to be after these injuries. I'm going to finish up here talking about medications very briefly because I could talk a long time on each of those. But we basically have 4 classes of psychoactive medications, although they overlap. There are the antidepressants. There's some studies now saying they really don't work. Well, that's because they don't always work. So if you do a study that says, well, does this always work? No, it doesn't always work, but that doesn't mean it never works. Antidepressants often can be effective. They're relatively safe. They're generally non-addictive, but particularly with people who, in lay language, like to at times get an adrenaline rush, like to have some excitement, particularly the SSRI and SNRI antidepressants, which are the most common ones these times, often create a flatness that takes away the ability to enjoy oneself or to feel things. If you read the literature, it will say sexual dysfunction occurs 10 to 20% of the time with SSRIs and SNRIs, more like 50 to 80% of the time. Obviously, depending on the person, but when you're dealing with people who, especially athletes, high functioning people, you give them something that's taking away their ability to function sexually, that in itself is going to be awfully depressing. You take away their ability to feel excitement, that's going to cause more depression. Plus, a lot of the antidepressants have a side effect of mild cognitive impairment, just mild effects on memory, on cognition. Your typical seriously depressed person who's taking an antidepressant and feeling better is going to see that as a minor trade-off, maybe not even notice it. On the other hand, if you're talking about someone who's already aware that they're cognitively impaired or not functioning like they like to, and then feel their cognition is slipping even more due to the medication they're on, you're going to have a counter-therapeutic effect. You have to be aware of the antidepressants. There are a couple, I won't go into details, that I tend to have less of those effects, Wellbutrin, Luvox, a couple that tend to have more of those effects, Paxil, but antidepressants aren't for everyone. And I'm going to jump to stimulants because stimulants are chemically close to antidepressants. Generally, they're used for ADHD, ADD, but we've always used stimulants at times as augmentations to treat depression, and particularly in people with head injuries, post-concussive. At times, the use of a stimulant is safer and more effective than an antidepressant. Have less side effects, and unless the person intends on misusing them, it often can be more effective, can improve cognition without having the negative effects, avoids the sexual dysfunction for the most part. The other advantage is the stimulants, you don't necessarily have to maintain a steady state blood level like you do with antidepressants. People skip a dose, they're not going to necessarily have a withdrawal, or they're not going to necessarily have an immediate reemergence of symptomatology. They can even be, the dosages can be adjusted more easily. So there are some advantages to that. You have to be careful with it, but there's something that I believe has to be seriously considered in dealing with post-concussive situations. They're often even more effective than antidepressants. Anxiolytic agents or medications that treat anxiety, almost all of them interfere with memory, interfere with cognition, and can cause impulsivity. Now, sometimes it's very minor or not really an issue, but just like we were talking with the antidepressants, even if it's subtle, someone who's already dealing with problems in that area, it may make things worse. Plus, a lot of them, the benzodiazepines, are potentially addictive, potentially cause dependency. I almost always avoid that class of anti-anxiety agents in people who have head injury and post-concussive issues. On the other hand, you have some agents like Buspar, which doesn't always work. It works maybe half the time, but when it does, it's nice because it's not addictive. It doesn't have the side effects. And also some of the mood stabilizers, which I have on bottom, also have anxiolytic effects. And some of those medications also will help with chronic pain, like gabapentin or Neurontin is basically prescribed for seizure disorders, but it's also prescribed for chronic pain, but it also can be good for anxiety, as can Lyrica, which is very close to gabapentin. So you really want to look outside of the box from the typical anxiolytics to mood stabilizers, other medications that might help anxiety with less side effects, but being aware that some of the mood stabilizers have their own downside. Mood stabilizers like lithium can cause flatness, just like the SSRIs. Some of them, Topamax is notorious for causing cognitive dulling. So you want to devise something that works for someone, that's as effective as possible with minimal side effects. But the other thing that makes it more complex is all of these things are going to change over time, because all the things I talked about before in terms of personal life circumstances, other stresses are going to impact what the symptoms are and how the medications react. So, if you see a psychiatrist who says, here's your prescription, I'll see you in 2 months, don't see him in 2 months. Don't see him or her again. You need to be able to sometimes just tweak a couple milligrams, but you need to be on top of what's going on. Maybe not daily, but at least a couple times a month. Otherwise, you're really not providing optimal care, and at times making things worse. I can't tell you the number of times where I've seen someone who was put on a medication. It didn't work real well, so 2 months later, the doctor's prescribing it, doubles the dose, which doubles the side effects. 3 months later, you have someone who's in the hospital or suicidal or drinking. Medications definitely have a place, but they have to be used very carefully and with full understanding of the interactions between medications, not only the psych medications, but is the person on pain medications? Are they on any other medications that might affect metabolism, liver, gut? I mean, it's extremely complex, which brings us to the last screen here, which is just the complexity of all of this, which I'm just going to summarize here. The human body is not a machine. It's extremely complex, and as much as we use it as a nice, convenient model, the brain is not a digital computer. If it's anything like a computer, it's closest to a quantum computer that most of us barely understand. It's surely not linear. We're dealing with multiple different inputs, which lead to multiple different outputs. And we're dealing with, to use a computer analogy, both hardware and software. What's going on neurologically and what's going on psychosocially, and how are those constantly interacting, as well as with society in general, whether you're talking about the pandemic, whether you're talking about politics, whether you're talking about just the information overload we have that, what I like to say is what used to be on page 16 of the local newspaper is now on Twitter and TikTok and everything else in milliseconds and often misrepresented. So we are in an age of information overload, and that has to be taken into account that the people we're dealing with are exposed to these same stresses and often are trying to cope with them. They're hard enough to cope with when you're totally intact, let alone when you're struggling with these other issues. We have to also have the humility to know that the knowledge of our workings of the brain, of the body, of humans in general is complex, it's limited, and often what we're doing is approximate. Sometimes that's good enough, but often it's not. We have to be aware of our limitations, and we have to be aware that whatever we do, the response is not going to be linear. Just because it works today doesn't mean it works tomorrow. Just because a low dose works now doesn't mean a high dose is going to work better. We're effectively dealing with, you put it all together, a mathematically stochastic system that's going to have predictable responses, probabilistic responses. Well, it may work, it may not work, and random responses. We're like, why the hell did that happen? I have no idea, but we got to do something differently. And to that extent, just to repeat what I said before, all the algorithms and guidelines, they're useful. We should know them, and we should know when to throw them out and when to say they work for the average person. When I see the average person, I'll stick exactly to that. But until then, I need to be able to understand that we're dealing with unstable, chaotic functioning of mind and body that we need to react to on a continuing basis. No one size fits all. What works today may not work tomorrow, and what may work for what looks exactly the same in two different people does not work the same way in the two different people. We need to think outside of the box. We need to integrate care. We need to not go overboard with saying, well, if this works, twice as much will work more. No, sometimes low doses of a couple different things that are fine-tuned on a regular basis works better than just staying with what the PDR or the algorithm says, and being able to responsibly think outside of the box and acknowledge that everything is trial and error. What works, great, stay with it. What doesn't work, look at another direction. Innovate when you need to, carefully, ethically. But if you're always doing the same thing, you're going to be effectively treating a small minority of the people you're seeing. I've gone very quickly through a lot of different issues, which is summarized here in terms of, again, the complexity of what we're doing. Please, any questions? And I'd be glad to go into detail about any of these issues in another time, another place. I hope this has been useful in at least providing a sense of how complex this is. There are definitely things we can do, psychotherapeutically, counseling, medication, supportively, cognitive behavioral work. But there's no one size fits all. We don't know a lot more than we know. We just have to keep struggling to do the best we can. Thank you very much, and we'll open this up as we can.
Thank you, Dr. Reiss, for that excellent presentation. We appreciate your time. My name is Courtney Welch. I'm a patient services coordinator at CLF. We have a few moments for some questions. We've already received a few great ones, but as a reminder, if you have any questions, please leave them in the chat or in the Q&A, and we will try and get to them. For the first question, Dr. Reiss, do mental health complications after a concussion typically persist beyond the recovery of the brain injury, or do you see that they cause long-term issues?
There's a wide spectrum, and I'm just hesitating because my view is somewhat biased because the nature of my practice is that I'm generally being referred to people who you're seeing long-term problems with, which is not funny, but the fact is that if someone basically recovers quickly, they usually don't get to me. So my view is somewhat biased in that view. But I think by and large, when we're dealing with significant concussive injuries, even after the neurological issues essentially resolve, assuming they do resolve, just as you had to adjust to the impairment that was there at the time, you have to readjust to being better. And often that's a significant readjustment that itself creates a lot of stress. So my response is more times than not, you'll see ongoing issues beyond what's neurologically explainable.
Great, thank you so much. Let's see, another question we have here. Are there any important differences in symptoms or history between men and women that should be considered?
Yes, in a lot of different ways. I mean, on a neurological basis, I defer to neurologists. And there are some hormonal issues that come into play that is beyond my expertise. There are also all the more social issues related to the stereotypes that we have in society as a whole, and as doctors and as therapists. The other very large issue that often gets overlooked is domestic violence. And how many times people who are coming in with head injuries, particularly women, even if it's a sports-related injury, may also have a history of having been subjected to domestic violence or just assault of some type, which is less frequent for the most part in men. And again, that's a generalization, and it changes over eras and time. But there definitely are issues, and that's why I very much support there being co-therapists. I think it's important for men to get a women's point of view and for women to get a men's point of view. And when you're dealing with sexual identity and other issues, I think it's important to get different points of view therapeutically, because the way people respond is different for both biological, well, not both, for biological, neurological, and social reasons.
Thank you so much. All right, last question here. Does a history of mental health symptoms prior to a concussion exacerbate the mental health symptoms post-injury or cause different symptoms compared to someone maybe without that previous history?
In general, yes. Now, there are some people, and I can think of a couple who I'm working with, who have a history of mental illness, but because they learn to cope with that, they actually have better coping mechanisms for dealing with the acquired issues that come about from concussion-related injuries. So it's not always negative, but I'd say 90% of the time, yes, you're going to have a combination of different issues or a reawakening of issues that maybe were quiescent. So for the most part, it's complicating and makes things more difficult and worse. But there are times it actually makes people more resilient.
Wonderful. Thank you so much, Dr. Reiss, again for your time and for this great presentation. And thank you all to everyone who has joined us today. Again, information on how to claim credits is in the chat, as well as information about future CMEs that we have available. Thank you all again.
Thank you all very much. My pleasure being here. Just to add, if anyone wants to contact me privately, my contact information should be available. Please feel free to. I do mostly consulting these days, but if anyone would like to contact me, please feel free to.